Well, hello, welcome. This is Here's to Your Good Health. My name is Linda Prezioso. I'm a nurse practitioner at Family Medical Center. And tonight, I'm so excited, we have a new fella in town. I had a new fella a couple weeks ago who was a orthopedic surgeon, and now we have an optometrist, brand new to town. And he is working at Rocky Mount Eye, and we have Dr. Robertson, who takes good care of my eyes. And so we are going to be talking all about eye health tonight. If you have any questions, give us a call, 407-1111. I want to introduce to you Caleb Lesnoff, who is an optometrist who has just started here. He's been here how long now, Caleb?
Just over a month now.
A month. Oh, you're really brand new. So he is working at Rocky Mount Eye and doing all the optometrist work. So tell me, what is an optometrist? What do you do there?
So taking care of the ocular health with prescription glasses, contact lenses, disease management and care, pharmaceuticals, everything up until needing for surgery, and that's when we work closely with colleagues, ophthalmologists.
Yep, that's right. So you can do you do like diabetic eye exams?
We do, yes.
Okay,
Yep,
so
take care of
any
those.
eye problem other than surgery you can pretty much handle?
A lot of them, yes.
Yep.
Most of them anyway.
That's right.
Okay, so you are originally from Virginia, I think you told me.
That's correct. Grew up in Northern Virginia, and then for college moved down here to an area called Anger, North Carolina for Campbell University. That's what brought me down here.
Okay, and you've been down here ever since?
Well, I did my training for optometry out in San Antonio, Texas. That was 4 years, but other than that, I've been in Anger between then.
Okay, and how did we manage to sneak you out of Anger to Rocky Mount?
Well, my wife and I were looking for a city, a little bit larger city that had some close by amenities, but still had that small town feel. And we're looking around, and Rocky Mount really fit that description for us. Came up to visit, really enjoyed driving around the area, and of course getting to meet with Dr. Robertson, his family there. It's really kind of motivated us to look in this area and come.
Awesome, that's great.
Yeah.
And I hear you have 2 little girls.
I do, yes. My wife and I have 2 daughters. One's about to turn 2 this Friday, and the other is 6 months old.
Wow. Ooh, curtain climbers.
Busy.
Yeah, busy, that's right. I like them much better when they're grown. But you got to start somewhere,
That's
right?
exactly right, yep.
Right. So you work full-time there?
I do.
Okay, what are your hours? How can I get to you?
We're there Monday through Thursday, 8 until 5, and Fridays, 8 until 2.
Okay. And so do people need a referral for an optometrist, or you can just walk in and say, I've got eye problems?
And for the most part, yeah, they just can call, and if there's any eye conditions that they're dealing with, whether medical or vision, just give us a call there. Some insurances may require a referral, but that's all something we can figure out.
Yeah,
Right.
yeah. And you've got people in the office that can do all that. I'm
Absolutely.
sure. Yeah. And so one thing that I really like about your practice is that there's always some slots open for emergencies.
That's correct.
And that's really important, because where else are people going to go for eyes?
Right.
You can go to the ER, but they're
Right.
not going to, I mean, they can do minimal, more than
Right.
I can do.
Right.
But a lot of stuff you've got to, be in your office. You've got the equipment, you've got the expertise. So I just think it's awesome. I wish more offices did that. Do you have gaps then, because people aren't full, or you find something to do to keep yourselves busy?
Coming up with the perfect schedule, it's sort of the holy grail. You know this. You dealing with people is messy.
Yeah.
And but and for eyes especially, there's a unique competence there that we bring to the community. And just thinking too, and my philosophy has always been, if somebody calls me with an emergency, all that I want the staff to say is, all right, how fast can you get here? And if, if it's another doctor in the community or one of our patients or whatever. And we really, frankly, kind of discourage our established patients from presenting to the ER. We really want them to call us first. And typically, we can very quickly identify the problem and take care of it for them, rather than them having to go through the whole ER thing. And there's triage going on there. They got to take care of people who are more desperately ill. So it's usually better just to contact.
The ER is, there's a place for it and we need it. But not for certain things. And eye injuries are one of them, especially now with all this COVID stuff. Lord have mercy.
Sure. Yeah, that definitely complicates, management and flow. And I'll tell you, anybody correct me if I'm wrong, but I would contend that our office has been probably the most aggressive in terms of very quickly, and that young lady sitting in the corner is a genius behind researching all of that, but very quickly, we went even beyond CDC recommended minimum protocols as far as screening, office cleanliness, and that. We invested in a HEPA filtration system, so every 10 minutes we're scrubbing everything out of the air in that entire building. And those things will kill 99+% of all viruses and bacteria in the air. And of course, we're following, CDC and government recommended mask protocols in the office and all that. And we sanitize the surfaces and all that. We've been hassling people to get in the door since probably March of last year.
Were you closed at all for the very beginning?
It
was so long ago.
Again, we were trying to follow recommendations of the CDC and our professional societies, and essentially, I guess, what was it, Lisa, about the month of April or so, we were sort of in limbo. March, we were sort of sputtering and slowing down. Essentially, for the month of April, we were on an emergencies only basis, which was at about 3% of our normal capacity. So around the early part of May, we just said, to heck with it. We've got our protocols down. We got our safety processes down. We're just going to open back up, with strict adherence to the distancing and the masking and the cleaning and all that. Just let patients make their own decisions, and so far, knock on wood, it's worked okay.
Good. And your office is like mine. We've got people that sit in the foyer and you ask the specific questions.
That's right.
And take your temp, and if you fail any of them, you got to go right back out the door.
We unfortunately made a few people angry there at the beginning, but if there's a fever, no, sorry.
Yeah, gotta go.
Go wait.
Yeah. Of course, when we treat people out in the back parking lot, we've got 2 tents out there. So if you have any COVID symptoms, you've got to go and sit in the car, and then I get to go out in the cold and the rain and the wet and
put on the suit.
I love it. I just love it. But you've got to do what's best for as many people as possible.
That's right.
And bringing sick people into the office is not gonna. It's not good.
Absolutely. So. And just the whole medical community. We've had to figure this thing out as we go.
Yeah, and we're still figuring it out.
We are. And like viruses mutate. So there are going to be changes.
Yes.
So this is just a fact. That's right. Fact of life. We just have to work with it.
I don't like it. I am so over it.
Yeah,
I know. I'm not alone in that boat, am I?
Amen. Yeah, you're right.
So, how many people do you see? I mean, I don't like. I have 15-minute slots. Is that about what yours is? I don't know how that works.
It's varying right now. Like we say, trying to figure out as far as the flow and everything, depending on who's in the office. I'll be some days every 15, other days every 10 minutes throughout the day. So
that's pretty fast, isn't it?
We're trying to get moving. We've got
you've
excellent help and staff.
Yeah,
so
you do. You've got great, and they do a lot of that. I call it prep work. I don't know what you call it, but so then when they get to see you, you just look right in the eye. All the rest of that stuff is
pretty
done.
much. Yeah.
Okay. So is it different up here than where you worked in Angier, or is
it is? It's a big difference, and it's in a great way. I came from a smaller practice. it was a little bit slower throughout the day, and this has opened up opportunities for more, medical treatment and something that I'm more passionate in.
Oh, good.
And so, yes, it's been wonderful in that aspect.
Okay. Do you have a favorite part that you love, glaucoma or?
Oh, you said it, yes. I enjoy managing and treating glaucoma. It's one of those where you can, with all the tests that we have, you kind of visualize and see the progression, as the time goes on, and hopefully our goal is not to see any progression.
Right.
And so, you got all these tricks and tools in your tool bag there to kind of manage and maintain, and the goal is keeping that pressure down in the eyes.
Right.
And so that's something we see lots of, and I enjoy managing that.
Awesome. That's awesome. And so do you do things like, I remember from my ER days, somebody would get a little fleck of steel in their eye from, we can come to the office and
Absolutely.
get that removed, that taken care
that is
of?
something we definitely take care of, manage, and get you healed up quickly for.
Yeah.
'Cause, that could be painful, and getting that out, we can have you feeling better before you leave even.
Corneal abrasion hurts.
Oh, very.
Yeah.
Yeah, very much so.
Does. It really does. So, I guess, do you treat children too?
We do.
Peds?
Absolutely.
So you don't have a preference over just adults or just kids? Or?
No, I enjoy working with children. I like being upbeat with them and making them feel comfortable. A lot of kids don't enjoy coming to the doctor, and we get to be one that, for the most part, they leave enjoying. So, no, I do enjoy
You don't poke them with needles.
No,
That's right.
exactly.
Like
shots.
those mean pediatricians
No shots.
do.
That's right. Yes. So they leave pretty happy with
Yeah.
smiles on their face, and so I do enjoy working with the children.
Okay.
Yeah.
So are there specific eye diseases that kids have, or it's just the same as adults? The eye doesn't work for one reason or another. Needs help with lenses. I don't know.
Well, one of the main ones we watch for in kids is amblyopia, which, the term a lot of people know as lazy eye. One eye is a little bit weaker than the other.
Okay.
And that does carry over into adulthood if it's not caught early on. And so that's one with children we really screen for. And glasses, is a first line of defense with that. Or and if it's a more aggressive case, then we get a little bit more aggressive with other treatments for it. So.
What are some of the treatments for lazy eye?
Yeah, patching. You cover the good eye to force the brain and eye to connect with each other, the eye that's a little bit weaker. And they do that, a few hours during the week, doing something they enjoy, watching YouTube or something like that. Exactly.
That's right.
But something that they're more relaxed doing, so they will partake in that treatment. 'Cause it's hard to get kids to kind of, understand why they're doing that.
Yeah, but then again, kids are so mean, so I suppose if you've got one eye that's going a different direction, they hear that too from their peers.
Sure.
So, okay, I forgot about amblyopia.
Yeah. That's,
All right, so I'm just trying to think. If questions specific for you, or we'll move on over to the big guy in the end. So how many days a week do you do surgery now, Dr. Robertson?
Well, currently Monday, Tuesday, and Wednesday, and if we have emergencies, we don't, fortunately, we don't have too many of those. We just kind of go whenever, if it's an open globe or something like that. But typically Monday, Tuesday, Wednesday.
Okay, and all day, those days?
Yeah, we do a half-day Monday, and then Tuesday and Wednesday. We're trying to work out some room flips, and that's the challenge again. Part of the hospital's defensive strategy, during this Coronageddon apocalypse, I call it, was to collapse all of the operating room services into the main pavilion, right? So now we have all the surgeons in the hospital. So we essentially shut the day hospital down.
Oh, you're not doing anything at the day hospital?
Nothing in the day. We strategically reserved that as an overflow ventilator ward. Remember back in the spring?
Oh, yeah.
We didn't know what was, we just didn't know.
Yeah.
And you see all these horror stories, people dying in Italy and France. Remember that?
Yeah.
So we all kind of said, well, what the heck do we do, right? So we had to make sure that we had enough personal protective equipment. We weren't even sure we'd have enough masks and gloves for the staff,
Yeah.
So we had to really it really reminded me a lot of the military days of triage and husbanding your resources. So part of that defensive strategy was all the surgeons are now working out of the pavilion. So that's it adds
challenge.
It adds some inefficiency to what we enjoyed down in the day hospital, and we're hoping to get back down there. But again, we've got to make sure that we have enough equipment and enough protections for the staff. And thankfully, in the eye business, we don't really get too directly involved in COVID management.
Right.
But it's a big deal. And
Yeah.
special wards at the hospital.
Yeah.
A lot of staff work very hard.
They
taking
work
care of
really
patients,
hard.
And
I can't imagine doing a 12-hour shift, taking all that garb on, all that garb off, how hot it is.
Yep, and I've done
boy.
a consult or two up there,
Yeah.
and oh boy,
Yeah.
make sure don't get that thing. But fortunately, and I know that the UNC epidemiologists had predicted that we would peak right around mid to late January-ish. And if you look at our inpatient census of COVID patients now, that seems to be bearing out. So hopefully, we'll see those numbers tweedle on down.
I hope so.
Yeah.
I hope so, because it's so insidious, because I get COVID, I don't even know I'm sick, and the next
Right.
guy is 45 years old and develops pulmonary embolus, and he's dead in a week.
Right.
I
Right.
mean, there's just no rhyme or reason. There's no way to really kind of.
I call it the Russian roulette virus. You
Yeah.
never
You're
know.
exactly
you never know
right.
when there's a round in the chamber when you get it.
That's exactly right.
And you're right. And there are certain age groups and risk factors that we know to look out for, and certainly the states that have been most successful in managing their populations have respected that. I mean, Florida in particular, genius down there. They actually set up a dozen specific COVID nursing homes, and anybody in that particular region that got it that was in a nursing home, they went to the special COVID nursing home. So they wound up without the sort of disasters that you saw in the Northeast. So that, it's all about proper management and screening.
Right.
But again, any person, any of us, randomly could get it and
Anytime.
go south.
Is there any eye involvement with COVID?
Conjunctivitis, fairly commonly. Beyond that, I'm not really aware of a whole lot else.
Yeah.
Although, as we learn more and more, I'm sure. And I've seen a few articles about finding viral particles in corneal tissue and such. But, like many other viruses, you can get a conjunctivitis with it.
Sure, yeah.
Which would be the most common
Yeah.
presenting eye complaint.
All right, it's time for our first break. Goes fast when you're having fun, doesn't it? So we will be right back after we hear from our sponsors with more of Rocky Mount Eye, Dr. Robertson, Dr. Lesnoff, and Linda Prezioso. So don't go away. We'll be right back.
At Downey's Hearing Care Associates, we are dedicated to taking care of every client by providing personal, high-quality hearing care services. My staff and I know hearing loss affects each person and their loved ones differently, so we give you the time and the care you need to ensure the hearing technology chosen fits your lifestyle. At Downey's Hearing Care, we also make custom ear molds and specialize in emergency hearing aid repairs. Downey's Hearing Care Associates has 2 locations, one in Knightdale and one in Rocky Mount. We have hearing lives to save.
I came to the emergency room because I was having what seemed to be an episode of AFib. I was very, very scared and wasn't sure exactly what was going on. They told me that they were going to do a catheterization. I was just totally blown away. The kindness, the compassion, the nurses, I was treated better than I've ever been treated in my life. I was just so excited that I could do it here at home at Nash UNC.
Hi, I'm Richard Koss, pharmacist and owner of Almonds Drug Store here in Rocky Mount. Here today with my wife and 2 daughters. For over 75 years, Almonds Drug Store has been the pharmacy of choice for residents of Edgecombe and Nash County. Our family is proud to call Rocky Mount home, and we are excited about the new services and products we are adding daily at both of our Almonds Drug Store's locations and also at our medical supply store.
Come in and see us at Almonds Medical Supply. We're an extension of Almonds Drug Stores, your local hometown pharmacy. We're here to service all your needs, from wheelchairs to walkers to orthopedic supports to compression hose to hard-to-find wound care supplies. And you'll always get that hometown customer service.
We want our patients to pay the best prices, get the best service available, and have a better pharmacy experience than they will get anywhere else. Our staff is committed to going above and beyond to meet our patients' needs. Whether it is working with your provider to get you the best medication at the best price, contacting your provider to get you refills or a prior authorization, or taking the time to review each of your medications with you personally, or perhaps even helping you find an old-time remedy or other hard-to-find items, your Almonds Drug Store staff will work hard to meet your pharmacy needs. At Almonds, we will deliver your prescriptions for free. Both of our stores have drive-through windows, we guarantee short wait times, and our pharmacists will come out to greet you personally and answer any questions you have. If you want to be met with a smiling face, or even want someone to greet you by name when you walk through the doors, we are the pharmacy for you.
Call Almonds Drugs today.
443-3138 or 446-0014.
Well, welcome back. This is Here's to Your Good Health. We are talking with 2 great guys from Rocky Mount I today, Dr. Robertson and Caleb Lesnoff. I'm going to get it right one of these days. I'm glad it's on the screen and I can watch it. Look, we're live tonight, and both of these guys would love to answer any question you have. So if you've got an eye problem, if you've been there and have, accolades to tell everybody, that would be great. They would love to answer any question that you have for eye health, so just don't be afraid to call. People say to me, I'll say, Linda, I watch your show. Good, why don't you call? I don't know what to say. Or I'm embarrassed. Well, who's going to see you at home when you're, but anyway. So call us, 407-1111. All right, I want to go back to the diabetic eye exam for a minute.
Sure.
I'm going to pick on you, Caleb. So, why do we have a diabetic eye exam? Why do we have to come and see you? Is it once a year, every 5 years? Tell me about it.
So, with patients who are suffering with diabetes, one of the things I talk to them about is letting them know, a lot of people think that it's a disease of high sugar, which sugar is what we're watching, but it's really a vascular disease. And in the eye is one of the only parts of the body where we can look in without special equipment and see the vasculature. And so in diabetes, if it goes uncontrolled, or if you had diabetes for a long time, we'll start seeing some changes in your blood vessels, whether it's a little bit of bleeding, that sort of thing. And so we can kind of co-manage with their primary or their internist to let them know, hey, we're seeing a little bit of change due to the diabetes in the eyes. We might want to think about bringing that A1C down. So you asked about how often we should check that. For a healthy diabetic, it should be about once a year.
Okay.
If we start seeing some moderate changes or to severe changes, we'll see them back more often. But healthy to mild, it's once a year to make sure everything's doing fine.
And so what's the the worst that can happen from diabetes in your eye?
Well, you talk about the worst is we can lose sight. And if we let those changes go on for too long without controlling them, it can cause some irreversible vision damage. And that comes from bleeding. Blood is essential to the body,
Sure.
but blood outside the blood vessels can be toxic to the eye.
And that's what happens, the blood vessels can leak.
They can leak, we can grow blood vessels that shouldn't be there, and those new blood vessels are weak and they can start breaking or leaking.
And if you grow new ones, does that affect how the eye itself works and all that? Or is there room in there for that to happen?
Well, there's room, but because they're not supposed to be there, it can cause changes as far as pulling or traction. That blood that leaks out as it dries up can pull on the inside of the eye, and that can cause other complications like retinal tears or detachments. And so we want to keep the eye from growing those new blood vessels. And part of the management for diabetic retinopathy is medical treatment with injections that slow down or help prevent those blood vessels from growing.
That makes me hurt.
I don't want to go there.
Well, but every patient that's ever said, they'll say, I had to go to the eye doctor and get a shot in my eye. They say it doesn't hurt.
Yeah.
Or minimally.
Right.
But I just can't
properly
imagine
done.
somebody coming with a needle to my eyeball.
Well, it's like, there's a substantial emotional component to pain. It's a lot of how it's handled. But yeah, a shot in the eye, it kind of freaks people out. But prior to that, what do we tell them? Say, well, sit down, we're going to take a laser beam. And you got to just look at this target, and we're going to put a grid laser in your eye. Or a pan-retinal photocoagulation. Those things hurt. Yeah. Oh yeah. So it's really a lot more humane to use the injectional therapies, and they work better, generally speaking. Not the vascular complications that Dr. Lesnoff was outlining. They also help just for plain leakage in the macula, just macular edema. They can help that. And we sort of stumbled into this as we were treating macular degeneration patients with shots. That was for the original FDA approval was for those, and we very soon learned that pretty much anything that causes swelling in the eye, these shots generally tend to help.
So is it like a steroid you put in there, or what?
Well, steroids can be used, so stuff like Kenalog or Triessence, but you get a lot of complications from those. 10% of patients get a runaway high eye pressure. If they don't have a cataract yet, you're going to give them one real quick by putting steroid in their eye. And most of the drugs that are used now are so-called anti-VEGF, or vascular endothelial growth factor, and that would include, I think the original one on the market was Macugen, which kind of came and went. Lucentis is the FDA-approved drug made by Genentech. No, not Genentech, DNA. I'm sorry, I'm getting old. I'm blanking on the name of the company.
That's okay.
It may have been Genentech. The stock symbol was DNA until they took it private. It's in Switzerland. Anyway, Lucentis is the $2,000 a shot version of that. Very chemically similar to that is a drug called Avastin, which we can have mixed up in a compounding pharmacy at about $20 a shot. And numerous head-to-head studies of those have shown that they work about the same. And then more recently, a drug called Eylea has come to market. And the advantage of that is, one, it works better. Two, you don't have to get it in the eye as much. And that's a so-called VEGF trap. So it works a little bit differently than the other drugs. And there's several other also ran drugs whose names I haven't really remembered, but they're being evaluated in trials and that. I'm sure we'll come up with other pharmacologic.
So is that a subspecialty, or do you all both do that?
We refer everybody to a retina specialist.
Okay.
I mean, I'm optometrist, and again, you asked Caleb earlier, what's an optometrist? And frankly, the lines between optometrists and ophthalmologists become more and more blurred as time goes on, and you get into what's the term I'm looking for? basically what you're legally allowed to do,
Yeah.
scope of practice
Yeah.
laws. And in some states, optometrists can do a lot of surgery on the eye, including injections and laser treatments and that. I'm licensed to do it, but I choose not to because I wouldn't do enough of it consistently to really be slick at it. So we found it's much wiser to have retina specialists do that. And we're fortunate to have, golly, if you draw a 50-mile circle around our office, you'll find more retina specialists practicing in that circle than you do either optometrist or general ophthalmologist, I would
Really?
bet you. Yeah, they're all over the place.
Is
so.
that because of a fascination for the retina, or is that because of a need, or both?
Both. AMD, the macular degeneration, is driving that train. And they're just running shot clinics.
And is that something that's genetic, or is it something that I could cause by not brushing my teeth or something? I mean, could you cause it by poor health?
Yeah.
Yeah, if you smoke a lot, it's high risk. And of course, diabetics, you want to manage your sugar properly and just do what your internist tells you, and that'll help you. But for AMD, if you smoke, very high risk. Epidemiologic studies have shown that if you eat lots of leafy greens, tends to slow down the progression. They've looked at vitamin C, vitamin E, vitamin this, that, and the other. If you get early macular, or actually somewhat beyond early macular degeneration, sort of moderate, what we call soft drusen, then supplementing with certain vitamins is helpful. Good, well-run NIH studies, basically the AREDS or AREDS formula, which included originally vitamins A, C, E, zinc, and copper, and then in the second study they found that smokers who took the vitamin A had an increased risk of lung cancer. So instead of A in the version 2, we now have zeaxanthin and lutein, I think.
That's correct.
Along with the other items that we mentioned. So we recommend everyone with a certain level of macular degeneration take those vitamins. If I have someone where it's in the family and they're concerned about it, even if they have very mild findings, I'll say, listen, what I'm getting ready to tell you scientifically is not defensible because we've not run the studies. The truth is we probably never will, and if I were in your situation, I'd look at it like a cheap insurance policy and just get the vitamins and take them. And in those same studies that defined the benefit of the vitamins in the high-risk population showed that they could also take Centrum, just a Centrum Silver, along with the other vitamin. And there was not really any vitamin toxicity. So, and it's amazing that just a simple over-the-counter thing will have, but it'll decrease the risk of getting what we call wet macular degeneration by around 25 to 30%.
That's a high
Just take,
percentage.
with an over-the-counter vitamin.
For
So,
$5 a bottle or something,
yeah,
$6
or
a bottle.
whatever they cost. But,
I don't know.
yeah, and I don't have any. I don't.
Here's our disclaimer.
Yeah, disclaimer. I don't have any of their stock, and they don't pay me to shill for them. But it's just good advice.
That's right.
But so, is the outcome of macular degeneration still blindness, or is it pretty preventable now, and that's not necessarily the final outcome, or comes and goes? Depends upon.
Depends.
Yeah.
Yeah, it's a lot better prognosis now with the shots than it was. The typical, in the studies that define the use of laser to treat wet macular degeneration, very well done studies, very highly respected studies. And I trained in the era where that's all we did. And I think when you were doing your optometry training, had the shots come out by that
They
point?
had, yes.
Yeah,
They
so
started.
Caleb kind of trained a different era. But the basic conversation would be, Mrs. Smith would come in, she says, Doctor, I woke up and I've got this big old blurry spot in the middle of my vision. It wasn't there when I went to bed, and here it was. So here she comes. And we look in, and now Mrs. Smith has a big swollen retina with a blood clot under it. So the dialogue would go something like this. Well, Mrs. Smith, you have wet macular degeneration now. We have a therapy that should help stabilize your vision. You'll have to take our word for it. We're going to do a laser for you. You're going to walk out of here with a bigger blind spot than what the one you walked in with, but you got to trust us that if you look 3 years out, if you let us do this laser now, statistically you're going to be better off visually than you would have been if we didn't do the laser. And the conversation now can be, well, Mrs. Smith, we can inject some medicine into your eye, And while we can't guarantee that we're going to make your vision better, in many cases we can actually improve your vision. And we couldn't do that in the laser days. There was always, you lose more to try not to lose even more later. But with the injections, we can actually improve people's vision in some cases. It's not guaranteed all the time,
Of course.
but at least that opportunity is there now.
Wow, so it's really come a long way. That's
Yeah.
great.
It has,
That's
yeah.
awesome.
Yeah.
Because, used to be a long time ago.
Yeah.
So we're just going to talk about, let's see, I want to go into uveitis, but we'll do that the next
Well, how much time before the break?
1 minute.
Okay, well, actually, one other thing I'm just reading about a little bit in macular degeneration. The most devastating vision loss is typically from what we call wet macular degeneration or exudative macular degeneration, where new blood vessels grow and they leak or bleed. But there's a subset of macular degeneration called geographic atrophy, where there's not really any wetness or bleeding, but still they wind up with profound central vision loss. And there are actually studies ongoing now looking at complement, the immune system complement chemicals, and they're basically some medications that can be injected into the vitreous. These are all still, I think, phase 2 FDA trial drugs. I just have been reading about these the last week or so. And I think Dr. Houghton, who was with us some years ago, was involved in some of those early studies up at Chapel Hill. But they've got some C3 inhibitors, essentially, I don't know the names of them yet, that actually seem to slow down progression of geographic atrophy, which is a thing we just haven't been able to treat before. But this is still, way cutting edge experimental stuff. It's not mainstream yet. But it is, as long as we can study things carefully and learn more,
Yeah. I'm grateful. All I ever had was cataracts. And I need glasses because I'm old, but other than that, I'm good. All right, we're going to take our next break. Y'all aren't calling us now. 407-1111, and we will be back in just a couple of minutes. Don't go away.
Yeah. Hey, Lisa.
At Down East Hearing Care Associates, we are dedicated to taking care of every client by providing personal, high-quality hearing care services. My staff and I know hearing loss affects each person and their loved ones differently, so we give you the time and the care you need to ensure the hearing technology chosen fits your lifestyle. At Down East Hearing Care, we also make custom ear molds and specialize in emergency hearing aid repairs. Down East Hearing Care Associates has 2 locations, one in Knightdale and one in Rocky Mount. We have hearing lives to save.
I came to the emergency room because I was having what seemed to be an episode of AFib. I was very, very scared and wasn't sure exactly what was going on. They told me that they were going to do a catheterization. I was just totally blown away. The kindness, the compassion, the nurses. I was treated better than I've ever been treated in my life. I was just so excited that I could do it here at home at Nash UNC.
When faced with special care needs for elderly or disabled loved ones, families want compassionate, comforting care. That's Tender Touch Home Care Services' goal, providing the level of care we would expect for our own. With over 10 years of home care excellence, Tender Touch provides an array of services that keeps your loved one at home. From personal care, light housekeeping, errands, and meal preparation, to our private duty care program, which combines all of our home care offerings in one package.
Tender Touch Home Care Services, where your needs are our concern.
Hi, I'm Richard Koss, pharmacist and owner of Almonds Drug Store here in Rocky Mount. Here today with my wife and 2 daughters. For over 75 years, Almonds Drug Store has been the pharmacy of choice for residents of Edgecombe and Nash County. Our family is proud to call Rocky Mount home, and we are excited about the new services and products we are adding daily at both of our Almonds Drug Store's locations and also at our medical supply store.
Come in and see us at Almonds Medical Supply. We're an extension of Almonds Drug Stores, your local hometown pharmacy. We're here to service all your needs, from wheelchairs to walkers to orthopedic supports, compression hose to hard-to-find wound care supplies. And you'll always get that hometown customer service.
We want our patients to pay the best prices, get the best service available, and have a better pharmacy experience than they will get anywhere else. Our staff is committed to going above and beyond to meet our patients' needs. Whether it is working with your provider to get you the best medication at the best price, contacting your provider to get you refills or a prior authorization, or taking the time to review each of your medications with you personally, or perhaps even helping you find an old-time remedy or other hard-to-find items, your Almonds Drug Store staff will work hard to meet your pharmacy needs. At Almonds, we will deliver your prescriptions for free. Both of our stores have drive-through windows, we guarantee short wait times, and our pharmacists will come out to greet you personally and answer any questions you have. If you want to be met with a smiling face, or even want someone to greet you by name when you walk through the doors, we are the pharmacy for you.
Call Almonds Drugs today.
443-3138 or 446-0014.
All right, welcome back. We're going to talk about uveitis because I want to learn more. I've had a couple of patients with it, and it's kind of a scary thing. It can be pretty damaging. So
It can be if it's not controlled.
Uveitis.
All right, well, uveitis is inflammation of the uvea, which is, I think, Greek for grape, which is sort of what it looks like if you dissect it out of the eye. So if you think of an eye, it's a spherical organ. The mucous membrane that covers the eye is the conjunctiva. That's what gives you the so-called bloodshot eye. You peel that back. You've got some muscles that are attached to the outside of the eye, and then you get to the white of the eye proper, which is called the sclera. And around the front part of the eye, the sclera gets clear, and we call it the cornea. Is that a call?
It is.
Oh goodness! Well, why don't we answer?
Hey,
the phone?
this is Linda, Dr. Robertson, and Caleb. How are you?
Hi, I'm good.
Hi. You have a question?
I just wanted to know, was Rocky Mount Eye accepting new patients?
Oh,
Absolutely.
I bet they are. And you will be very happy over there. I've been over there for,
Really?
yeah. I mean, I used to go to Susie Watson before you bought from her.
Okay.
So, yes, well, come on over.
Okay.
All right, thanks for calling.
Thank you so much.
Bye. I'm glad you said that because I don't
Yeah.
pay attention to the daggone phone. I want
Yeah.
people to call, but then I don't pay attention to the phone.
Yeah.
So, all right, we're good. You're taking new patients.
Oh, absolutely.
Yeah.
Yeah. It's the lifeblood of the practice. Yeah.
Okay, all right. All right, back to uveitis.
Yeah, so anyway, you've got, the eye's got multiple layers. The sclera, the cornea, sort of the outside layer, once you peel the muscles back. And then the layer inside of that is the uveal tract. And that's, in the front of the eye, it's what gives our eye color, the iris, brown, blue, whatever. But that tissue extends further back underneath the white of the eye. And there's the next layer back will be the ciliary body, and that's what holds the lens in your eye through little fibers. And then behind that is what's called the choroid. And that's basically a very vascular area underneath the retina, which lines the inside back of the eye. And I wish, Lisa, we should bring maybe a diagram the next time in case we need to show that.
Yeah, that'd be good.
Anyway, the uveal tract can get inflamed, just like a joint can get inflamed, or like your pericardium can get inflamed, or whatever. And so the generic term for an inflamed uvea is uveitis, and we subdivide that into iritis, which is an inflammation of the iris in the front of the eye, which, for example, 100% of our cataract patients get for a short period of time after surgery. Or there can be inflammation of the iris and the ciliary body behind it, so-called iridocyclitis. Little terminology there. And typically when the ciliary body gets involved, it's crampy and it just squeezes down. And that gives you the sort of classic symptom that we call photophobia, which is where you get this toothache, like crampy pain in your eye when it's exposed to light. And usually the vision's blurry and the eye's red and angry. So if you get that sort of symptom, you need to let us know. And the other symptom that can masquerade that way would be a rare form of glaucoma called angle closure glaucoma, or in the diabetic patients like Dr. Lesnoff was describing earlier that are growing new blood vessels. Those can involve the iris and can cause similar symptoms. So we have to think about, differential diagnosis of all these complaints. But basically, any portion of that uveal tract can get inflamed. You go further back to the choroid, which is underneath the retina, and if that gets inflamed, you call it choroiditis. And then that can cause damage to the retina that depends on the choroid for about 2/3 of its blood and nourishment supply.
Ooh, that's a lot.
And you could wind up with permanent vision loss from that. So it can be very dangerous. Most of the cases we encounter are these self-limited post-cataract episodes, although we do see a fair number of people that just, for whatever reason, get an iritis attack, and much more rarely we'll have patients that have inflammation further back. And risk factors would be things like autoimmune disease. If you have rheumatoid arthritis or lupus or sarcoidosis, fibromyalgia, I've even seen people come in with that. If you've had any sort of surgery to the eye or trauma to the eye. In regarding trauma in surgery, another concept is called blood ocular barriers.
Oh, we got another
and
call.
we'll get to that after the call.
Hey, this is Linda. How are you?
Hi, I was just calling. I saw you guys on the TV, and I wanted to let you know my aunt just went there the other week, and she was just wondering where Dr. Robertson got such a good and smart clinical staff from.
Well, it takes a while to train that clinical staff, and we're very fortunate to have such a wonderful clinical staff. It takes a long time to find them and train them and retain them, and I'll tell you, we could not do what we do.
Are you guys accepting new patients? Because if y'all are that good like she says, then I need to get my eyes checked. It's been a couple years.
Well, you need to give us a call. And actually, there's a number right on the marquee there, 443-1006. Give us a call 8 o'clock tomorrow morning, and we'll hook you up.
I'll do it. Thank you so much. I look forward to meeting your staff.
Yes, indeed. They're wonderful.
Bye. All right.
So during the development of the body, the immune system in our bodies does not see the proteins inside of our eyeball, just because of the embryology and the steps, during which all that develops. So whenever there's a break in one of these so-called blood ocular barriers, and there are essentially two of them simplistically, the blood retina barrier in the back of the eye and the blood aqueous barrier up in the front of the eye, anytime you physically violate that space, immune cells get to see the proteins in the eye. And since they're foreign, you get an immune reaction. And again, classically with cataract surgery, even though we make microscopic incisions to get into the eye, we're opening the lens up, right, and sucking all the protein out of the lens. And man, that's just all kinds of crazy protein in there that the immune system's never seen, so it reacts to it. And that's why we give people steroids and essentially liquid Motrin drops post-operatively, and that manages that immune reaction. Typically that goes away in a few weeks. But if you've had previous surgery, and again, we see, we're in we're in diabetes central here, right? So we see so
Yes.
many patients
Yes.
who've either had multiple shots, and that violates the blood-retina barrier every time, or laser treatment or retina surgery, you know, and then we do the cataract, then the immune reaction is going to be enhanced and run a lot longer.
Oh, my goodness. Hey, this is Linda. Here's to your good health. What's your question?
Yeah, I was asking Dr. Lesnoff, does he do contacts?
Absolutely. Yeah, we do contact lenses. We evaluate them, different types. We got anything from single vision to astigmatism and bifocal contact lenses. So yeah, we can fit whatever you need.
Awesome. Okay, thank you so much.
Absolutely.
Thanks for calling. See, astigmatism, you can have contacts? My husband had astigmatism and he couldn't wear them.
So they've come a long way with contact lenses. It used to be, astigmatism severely limited your options, and because contact lenses are becoming much more popular, especially right now with masks. They don't fog up like glasses do. Companies are really working to come out with a wide range. So yeah, they're a great option, and we can fit almost anybody in them.
Okay, I just can't. Anything that goes to my eye. I mean, you should have seen me. I had cataract surgery and my husband fought with me. I was like a little 2-year-old getting these drops in my eye. I'm ashamed to say.
You got them in, though.
I got them in and I'm okay. And
Good,
everything's
good,
good.
yeah.
But, so we're going to back off of uveitis, and I just want to talk a little bit about your optical. You've got a spot there for glasses and fitting, and how do you fit for contact lenses? Because I don't know, I'm never going to have them, I don't think. But I go to you and you write my prescription, and then how does that work?
Yeah, we'll take a call here, and then we can.
Okay, sorry. I'm glad they're watching.
Yeah.
Hey, this is Linda. Here's to your good health. How are you?
Yes. What causes detached retina?
I don't know if we can fix that in 3 minutes, but we'll try.
Okay.
I'm going to hang up, Sugar, unless you
Sure.
have another question.
Okay, thank you.
All right,
Okay. In the United States, the number one cause of detached retina is having cataract surgery. It's
You
a
didn't
rare.
tell me that
It's a rare No, it's in the paperwork. It's a very rare complication. It only happens maybe once every 1,000 to 2,000 cases, very broadly. But since we do about 1 million cataracts a year here, and in an unoperated eye, the risk of detached retina across all age, race, sex groups, whatever, is around 1 in 10,000. We raise that percentage from a 1 in 10,000 risk of just randomly having one to about 1 in 1,000 to 1 in 2,000. So that would be the biggest risk. If you've had any sort of disease process that affects the retina, Dr. Lesnoff already in his discussion of diabetic retinopathy alluded to a very significant risk factor for that, which is scarring in the eye. And those can be some very, very difficult to manage if there's scar tissue and a torn retina. Very hard to manage those. That's why we're fortunate to have so many retina specialists around. So cataract surgery, sequelae of diabetes, sequelae of runaway uveitis that involves inflammation in the back of the eye with retinal swelling and leakage from that. Trauma can do it. And then certain people will have certain congenital syndromes where there's an increased risk of detached retina, or people who are extremely nearsighted, have very long eyeballs. And think about it, each eyeball has a set number of cells inside the eye. So if you have a longer eye than average, it stretches everything, and there can be weak areas. We look, typically there's a structure called lattice degeneration, and lattice is kind of interesting. Most patients with lattice degeneration don't have a detached retina, but if you look at detached retinas, I think it's over 25% of RDs are going to be in patients who have lattice. And the critical thing to remember, and I tell patients, I like to try to simplify things, as much as possible. I tell patients if they see what reminds them of a thunderstorm, to let us know, and that would include flashes of light, classically off on the side, or they can look like a ring flash. So flashes of lightning, heavy shower of new and different floaters, and this can look like pepper coming out of a shaker. It can look crimson red like blood. You can also get kind of what we call tobacco dust pigment, so they can have different colors. But so flashes of light, a bunch of new floaters, and most ominously, if you get a big cloud that comes in and blocks out your vision from any direction, you don't sit on that. You get into the eye doctor right away.
Yeah, that's right.
Absolutely. You get us on the phone and we say, all right, how soon can you get here?
That's right.
And we figure out what's going on.
Okay.
But that's kind of just a general overview.
Yeah.
Yeah.
All right. We're done for the night. We could go on for another hour, couldn't we? But Randy's right behind me, and I don't think he'd like that. Thanks so much for coming, Caleb. It's so
Absolutely,
nice
yes.
to meet you.
Thank you very much for having
Welcome.
us.
I'm glad that I got to meet you.
Yes.
Dr. Robertson, it's always good to see you.
Absolutely.
And we've
Fantastic.
got the brains of the outfit back here on the couch. She never comes on, but she's the pretty one in the family, too. Anyway, we'll see you next week with more of Here's to Your Good Health. Good night.
Thanks.